Laurent Pierrot. Laurent Pierrot is professor of biology in the basis of Rennes, France, and head of Department of Biology in the University Hospital from 2001. He was the president of French Society of Neurobiology from 2007 to 2011, and zero secretary, and then president of European Society of many invasive neurobiology, neurological therapy, SP, from 2016 to 2018. He has published more than 250 papers in the most important journals of neurobiology and vascular disorder in Britain. He is the center editor of Innovation Biology Austria and member of the editorial board of AGNR and Neurobiology, and was editor-in-chief in Journal of Neurobiology and associate editor of Journal of International Society. Also, Laurent Pierrot presents the topic endovascular treatment of intracranial aneurysm is the still best of styling. Also, Laurent Pierrot, please.
Thank you, Professor Fabi. Before starting, I want to congratulate myself and Professor Phion for the development of the Vietnamese Society of International Radiology. Congratulations, it's now a very big and large it's very important for the development of international radiology in Vietnam. So now I want to discuss with you on vascular treatment of intracranial aneurysm. They are my disclosures. So since the publication of ISAT's results in 2002, coiling is the first line treatment for intracranial aneurysm, but we met two limitations from the beginning. One is the fact that we have a relatively high rate of organization after coiling intracranial aneurysm. In ARETA, we are evaluating the rate of organization to be 30% of aneurysm. And also the second problem was identified, which is the fact that with coiling alone, it's difficult to treat wide neck bifurcation aneurysm. So for this reason, I showed here an example of localization. It's a large ICA aneurysm. We were treating this aneurysm with coils, but you see that after 1 year, we had a large localization of the aneurysm. So it's something we see with all type of aneurysm, all sizes of aneurysm, but mostly with bigger aneurysm, large and giant aneurysm. So due to that, several techniques were developed at the time. One was balloon-assisted coiling, which is the placement of the balloon in front of the neck to support the coils in the aneurysm sac. And subsequently, we have the stent-assisted coiling, which is more or less the same principle to support the coil in the aneurysm sac. Maybe it prevents also organization, but it was never demonstrated purely in a randomized control trial. Flow diverter was the further development. It's a dense mesh stent which can allow to treat an aneurysm. And finally, the last development was flow disruptor. The most important one for the time being is web. I will discuss the place of this different technique in the management of intracranial aneurysm. So, the selection criteria for the treatment of intracranial aneurysm, for the selection of the technique, we have to use aneurysm anatomy, that is the rotation of the aneurysm. Is it a bifurcation aneurysm, sidewall aneurysm, is it anterior or posterior circulation? We have also to take into account the size of the aneurysm, small aneurysm, large aneurysm, giant aneurysm, and also the neck size is important to decide which technique we have to use. An important factor is also the aneurysm status, rupture or unrupture, because some techniques cannot be used for the time being in ruptured aneurysm due to the need of drug-treatment, similarly for stenting and full diversion. So first of all, I will discuss ruptured aneurysm. So, using permanent intraarterial devices like stent-assisted coiling or fluid inversion is not indicated in ruptured aneurysm, at least in the acute phase, due to the need of drug-treatment treatment. Maybe it will change with the development of surface modification, like HPC from Phiên, for example, or machine from Medtronic, but for the time being, we don't know if it works. So we need to evaluate that. Small aneurysm, we have two options to treat ruptured aneurysm, which are coiling, including balloon-assisted coiling, and flow disruptors similarly well. For large and giant aneurysm, we can use stage procedure, which means we will do coiling at the acute phase of bleeding to protect the dome, which is a more frequent location of rupture, and we will place the fluid inverter after several days or weeks. So just to show you here some example, ruptured and ACOM aneurysm. You see the aneurysm, which is very small here. The only option in that case is to place the coils in the aneurysm sac, which will give a complete aneurysm infusion. Balloon-assisted coiling is highly indicated in ruptured IA, not only to facilitate the placement of coils in the aneurysm sac, but also to stop bleeding in case of intraoperative rupture. If you have a rupture of the aneurysm during the placement of coil or during catheterization of the aneurysm sac, you will inflate the balloon in front of the neck and stop immediately the bleeding. I show you an example here. Ruptured PIEROT aneurysm during the placement of the first or second coil. You see that we have a large externalization of contrast showing a rupture of the aneurysm sac. So what we are doing is we immediately inflate the balloon in front of the neck and continue to place coils to stop the bleeding. So balloon-assisted coiling is a very useful technique in the treatment of ruptured aneurysm. Also, flow disruptors are now useful for the treatment of ruptured aneurysm, as was demonstrated in Clarice study conducted by LAURENT. This study was accumulating 60 patients with ruptured aneurysm treated with WEB, and it was showing that after 1 month and after 1 year, there was no bleeding of the aneurysm treated with WEB. So again, flow disruptor is a good indication now for ruptured aneurysm. Similarly, it is demonstrated for WEB, but for the time being, it's not demonstrated for control. So I show you an example, ruptured PIEROT aneurysm, placement of the WEB. You see that immediately after the placement of the WEB, you have no more contrast filling in the aneurysm sac. So you prevent the remaining of the aneurysm sac, the aneurysm. And you see here the control angiogram at 1 year, which shows a complete aneurysm infusion. Here another example, ruptured ACOM aneurysm. You see that it's a wide neck aneurysm, difficult to treat with the coiling or maybe with balloon-assisted coiling, but here we decided to treat the aneurysm with the WEB again. We use the WEB SL7x3. You see the placement of the WEB, and it was preventing bleeding of the aneurysm. It is the end of the procedure. You see that at the end of the procedure, you don't have any more contrast filling in the aneurysm sac. Here, ruptured large ICA aneurysm in carotid-ophthalmic position. In that case, you cannot use flow disruptor, I call it, because the aneurysm is too big according to the available sizes of web. So the option here is to treat, to coil the aneurysm, and if necessary to place the flow diverter, but not at the acute phase, but several weeks or days after the treatment. So you see here the initial coiling was good, but you see that 10 months later you have a large localization of the aneurysm, and we were placing additional coils on thread 3.5 by 17 by 11, and value of the term we had a complete aneurysm. Now for enriched aneurysm, the strategy is a little bit different because we can use assisted coiling and flow diverter. So for small aneurysm with a small neck, whatever there are bifurcation or sidewall aneurysm, you can use coiling for sure, including balloon assisted coiling and stent assisted coiling. You can also use flow diverter, flow disruptor. So all techniques can be used in this situation. Indeed, coiling is very often sufficient. You see here small carotid ophthalmic aneurysm for acute discovery, treatment with balloon-assisted coiling, and you see that we have a complete aneurysm occlusion at 12 months, so it's simple to do. Here another example of carotid ophthalmic aneurysm, a small one with relatively large neck. So in that case, what we were doing, we were not using coiling, but we were using flow diverter. So you see the placement of the flow, the deployment of the flow diverter. It's a P64 4.5 plus 15, and it's end of the procedure. We have a good stagnation in the aneurysm site. We have 6 months and 12 months. We have a complete aneurysm. It's small aneurysm with a wide neck, singularly the level of the bifurcation. We can use balloon-assisted coiling or stent-assisted coiling, but very often we need 2 balloons or 2 stents. So probably another option is flow diversion, eventually associated with coiling, singularly when it's a large aneurysm, it's a relatively large aneurysm, or a very good option is for sure flow disruptor web. So I show you an example, wide neck ACOM aneurysm, we place a web essay 5x3. At the end of the procedure, at 1 year, sorry, we have a complete aneurysm occlusion. You see that we have now a long-term follow-up for this kind of treatment with 3 year and 5 year, and we're showing a stable complete occlusion. Here, another example. Wide neck MCA aneurysm, placement again of a web SL7x3. We have a small neck remnant, as you can see, but you see that this very small neck remnant is quite stable all the time until 5 years. Here another example, it's a wide neck ACOM aneurysm. You see that it's a shallow aneurysm. In that case, it's not easy to treat with web according to the sizes available. So in that case, we are using a contour 7 mm, and you see that we have a good placement of the contour in the aneurysm sac. So it can be useful to use this device in that case. You see that VasoCT is very helpful to check the position of the device, whether it is a web or contour or even a flow diverter, to know if the device is properly placed in front of the aneurysm itself. For small aneurysm with a wide neck, when it's a sidewall aneurysm, we can use balloon-assisted coiling, stent-assisted coiling. We can use a flow diverter, virtually associated with coiling and flow disruptor. For a large aneurysm, we can use, the better is to use a flow diverter to avoid recanalization and to place coils in the aneurysm site to prevent direct aneurysm rupture, which was demonstrated in the past. So here I show you an example. It's PIEROT aneurysm with a wide neck aneurysm. So in that case, we are using coiling plus flow diverter P64. So you see we have 2 mic, one for the coils, one for the flow diverter. So issue 10 for the coils and L1 for the flow diverter. We deploy first the flow diverter always easy to deploy singularly for the treatment of peak of aneurysm if we want to avoid to cover the A1 segment. So you see here, at the beginning we started to deploy the flow diverter from M1, but we were not successful to properly deploy the flow diverter. So in that case, sometimes it's useful to deploy from A1. So you deploy at the beginning from A1, you pull back the flow diverter and it will place immediately below the ICU unification. So I'll show you this. This is the placement of the flow diverter. We place coils, and finally we have complete aneurysm occlusion at the end of the procedure. Here also example is unruptured IC aneurysm, large one. So in that case, I think it's a very good indication to place a flow diverter and to place coils in the aneurysm site. So you see the placement of the P64 and the placement of coils in the aneurysm site. And this is the end of the procedure. We have complete aneurysm occlusion, and the follow-up shows stable complete aneurysm occlusion. So the take-home message is that we now have a lot of techniques that we can use. You see that in Athena study, which was conducted in France, with a lot of aneurysm treated 1,356, you see that coiling was still the first line technique, singularly in ruptured aneurysm, a little bit less in unruptured aneurysm. There is an increasing use of flow disruption web and flow diverter. In a recent study that was again conducted in France with 250 patients, coiling is still, this study was conducted for unruptured aneurysm, and even for unruptured aneurysm, coiling is still the first line technique with more than 70% of aneurysm treated with coil. So we have several techniques, but coiling is still useful, but sometimes you will have to select flow diversion to avoid recanalization or flow disruption with web, which is a very efficacious use, very safe, and very easy to manage. Thank you for your attention.